Hi everyone and welcome. Thanks for joining us. We're going to go ahead and get started here, but I'm going to do a few housekeeping items before. If you haven't already done so, please mute your lines. We will have time for questions and answers at the end. You can either type in the chat box or click the raise hand icon up at the top bar. Turn off any applications or close your windows you're not using to help conserve bandwidth. A recording of this will be posted to our website later today or tomorrow. And then you can download today's slides down at the bottom right pod. And so I'm happy to introduce our speaker, who is Dr. Paul Ravenna. Dr. Ravenna is a lifelong Chicago native. He completed his undergraduate degree at the University of Illinois, then moved on to medical school at Rosalind Franklin University. He completed his family medicine residency training with Northwestern Family Medicine Residency Program in Humboldt Park, and is currently faculty at Northwestern's Lake Forest Family Medicine Program. And so with that, I'm going to go ahead and turn it over to Dr. Ravenna.
Thank you very much, Lauren. Thanks for everyone today for taking time out of your day to participate in this discussion about using geospatial data resources to teach social determinants of health. I'm fortunate to be working with Drs. Wright, Ryan, and Clements on this project. We all work as part of a larger collaborative at Northwestern, the National Collaborative for Education to Address the Social Determinants of Health. It's easier to remember, the NCEAS. Northwestern received a grant from HRSA to study social determinants of health in different settings, in both undergraduate and graduate medical education. We all work along with many other colleagues here at Northwestern as part of this collaborative. So today, we're going to start by with a brief discussion of a survey that we did that I think highlights the need for teaching social determinants of health in new ways. We're going to go over a selection of GIS products that are currently available. This is not going to be a comprehensive list because there are a lot, as I'm sure many of you are aware, but we will go over a few just to highlight different capabilities and some things to consider when you are choosing a product. And then we'll move on to a pilot project that we did in one of the residency programs here at Northwestern and end with some next steps. Since we're going to be talking a lot about social determinants of health today, it probably helps to define it. You can do that in a lot of different ways. This one from Healthy People 2020 is as good as any. We all sort of know, and perhaps this is preaching to the choir a little bit, but we know that these are critically important factors with a very real impact on the health of our patients. We should also probably stop to define GIS because I'm going to be saying that a lot. That's Geographic Information Systems. It's data mapping technology. I think if you had to oversimplify, that's what I would say. I also want to put it out there that I am not a coder. I have zero computer programming background. The good news is you do not have to in order to use this technology clinically. It's pretty easy, pretty straightforward, pretty easy to wrap your head around. The bad news about that is that if you have any technical questions, I probably have the same question and won't be very helpful for you. So when the collaborative first got together, we started by conducting a survey of family medicine and internal medicine residents at Northwestern. Northwestern actually has 2 family medicine residency programs, soon to be 3. One is located downtown, one is located in the suburbs of Chicago. And we did that in order to sort of gauge the experiences and perceived skills to date when it comes to residents addressing social determinants of health with their patients. Now, what we found was that 84% of our residents, a pretty impressive number, reported experiencing or being taught about social determinants of health and having had some sort of training in medical school. That was impressive to us. We were happy with that. Northwestern is a large academic medical center, multi-specialty, tertiary care, in the greatest city in the world. So we have medical students from all over the country choosing to continue their medical training and do residency at Northwestern. So while not all medical schools in the country are represented here, it's a pretty decent representative sample from schools from north, south, east, and west. So 84% is a good number. The problem is that it doesn't seem to be working very well. So only 28% thought they were any good at identifying determinants of health with their patients. And that number cuts in half when you start asking if they think they can discuss these issues or these challenges with their patients. You'll notice that we didn't actually even bother to get into actually addressing the issues. So when we first got this data and we were first trying to work our way through it, one of the members of the collaborative, maybe playing devil's advocate a little bit, said, well, is this a bad thing? Is this 28% who can identify social determinants of health a bad number? Because that was our initial instinct. There's a lot to accomplish in family and internal medicine residency. You have inpatient and outpatient responsibilities, you've got QI and scholarly projects, leadership. In family medicine, you're catching babies. Maybe you're preparing for fellowships as well, particularly in internal medicine. So there's a lot to do. So if only 28% can identify social determinants of health, is that bad? And we all said yes, that that's not okay. We think that identifying social determinants of health is a core component of training, particularly in primary care. It's a key skill that all residents should have when they graduate. And another member of the collaborative made what I thought was a really useful comparison to another key skill that we all teach our residents, which is EKG interpretation. So if you had a little bit over a quarter of the residents in primary care, in family medicine or internal medicine, who could look at an EKG and tell you if it was normal or not, or only 14% of them could actually tell a patient your EKG is normal or not, would that be okay? And we all very quickly, again, said no, that would not be okay. If that were the case, found, we would very quickly be trying to find new ways to teach that. So just like EKG interpretation is a key piece of training in family and internal medicine residency, so is identifying and addressing social determinants of health. So if we would find new ways to teach EKGs, we should find new ways to teach social determinants of health as well. It's also our job to do that. So these are the milestones for the graduate medical educators who are listening in. You'll be very familiar with these. You'll remember, so for those who aren't familiar, these come from the ACGME. This is how we track residents' progress through residency. The goal very much is progression, so not everyone's going to be a level 5. Not all attendings are level 5 in all of these different domains. The goal is progression. We're looking for a level 4. Level 3 is sort of a bare minimum requirement. And here in one of the family medicine milestones, you see that identifying social determinants of health is considered a bare minimum requirement for graduation. The ACGME also has common requirements for all programs. So this is not just family medicine and internal medicine. This is the ENTs and the pathologists. Everybody needs to know how to do this. While the wording is a bit vague, it does sort of hint at social determinants of health training. We are hopeful that more specific wording will be included to more accurately reflect the importance of social determinants of health training for all specialties. Moving on, we've identified that it is important to teach this and that maybe we need to find new ways to do that. Some of my colleagues in this NCAS, this National Collaborative here at Northwestern, conducted a comprehensive literature review to try and identify best practices or a framework for social determinants of health curriculum to see if we can try to come up with more unified ways of teaching the topic. The major findings from this scoping review were presented previously in another webinar, so I'm not going to get into all of it. Again, if we had to grossly oversimplify things, there are a lot of educators across the country in both undergraduate and graduate medical education settings who are doing a ton of great work. It's very heterogeneous, so there's the curriculum varies widely in development, in content, in implementation, and particularly in assessment. So it makes it really difficult to identify best practices and say this is what we should all be doing. This is a shameless plug for the collaborative website here, where we have consolidated a list of curriculum resources for those who wanted to have a little bit more information. Those resources are categorized further by undergraduate and then graduate medical education settings. So if you're looking to see how you stack up to your colleagues across the country, if you are looking to make a change or implement something new at your host institution, this is a resource that we hope you will utilize. So the survey that we did at Northwestern to start off showed difficulty in assessing and discussing social determinants of health with our patients. but we want to go a little bit further. We want to move into actually addressing these issues. So using that EKG example that we talked about a minute ago, it doesn't help that much to be able to tell a patient that your EKG is wrong if you can't do much about it, if you don't know what the next step in treatment is. So we think that GIS resources, this geospatial mapping, potentially can help us kill two birds and facilitate discussion, but also matching patients with resources and move towards sort of that higher level of addressing social determinants of health. Here again, we're going to go through a few different currently available GIS products. Again, it's not comprehensive, but we'll talk about some of the differences between them. If you have other products that you use, we'd love to hear about them at the end. The first one is the Community Health Navigator. We're not going to talk much about it right here because we ended up using this for our pilot study, so we're going to talk about it a little bit more later on. Moving on to Aunt Bertha. Aunt Bertha is a great resource. It's free, it's easily accessible, it's very easy to use and navigate, and pretty comprehensive. As we've gone to different conferences in different parts of the country and started presenting some of the work that we've been doing and talking about GIS products, Aunt Bertha seems to be one that's catching on quite a bit in different parts of the country. A lot of people who are becoming more familiar and using this and starting to implement it into their workflow. And it's easy to do that. All you have to do is put in a zip code where you're working, or a patient's zip code, and you will get a ton of resources that pop up. Easy to navigate, nicely sort of organized at the top with all of these different tabs. For the sake of this demonstration, we should have went on the Health tab. Why not? We're all super biased to healthcare providers. So we went with the Health tab. Now you'll see all these new tabs on the left. If you go on the Addiction and Recovery, which is what I did, you'll see that there's 71 services in the area where I work for addiction and recovery. I think before I used this, I probably could have named 3. So maybe those 3 won't work for everyone, or maybe they're not the best options. So I do think that it's great to have these different resources available. You can filter this even more based on different factors for your patients. So here we're on nutrition education. We're away from that addiction and recovery, but looking at some nutrition resources, you see that you can filter by cost, by access, by language. These are all very real barriers faced by our patients. And this particular technology allows you to filter your search by whether or not they're free, whether they speak your patient's language, so that you know you're providing resources to patients that they can actually utilize, which is incredibly important. And once you've done all of that, you'll get some more information. If you look in the bottom right of the screen, you'll see that connect button, so you can actually engage with the referral center. You can send them a message, say, I want more information, I'm interested in sending patients. You can give them a heads up that you're sending a patient their way. So you can do a lot with this particular GIS product. Some of the reasons that we didn't choose this, so one, at zip code level data, we were looking for a little bit more granularity. We could get into a big discussion of zip codes versus zip code tabulation areas. If we have time for that at the end, maybe we'll get into it. Just suffice it to say that zip codes are not always as accurate. You also see here that it gives you a distance. Now, when we were going down the list of resources, some of the distances were 20 or 30 miles. The area that we serve can get pretty rural, so maybe that's just the reality, that if you want to get to these places, you're going to have to travel. But I don't know how realistic it is to give our patients resources where they're going to have to be going 20 or 30 miles, particularly when you're thinking about social determinants of health and transportation. These might not be realistic for some of our patients. Another great resource is the UDS Mapper. So we're moving on from Aunt Bertha into the UDS Mapper, which was developed through a partnership between Health Landscape, the AFP, and the Graham Center in Washington, D.C. It is a very powerful tool for population health. So we'll start, for this demonstration, we just put in addresses of one of the areas that we serve in our program. And you'll see the map. And on the bottom left, you'll get some basic population data. So before you really do anything, you get a bit of a snapshot of the area where your patient's living or the community that you're serving. One of the nice features about the UDS Mapper is that you can change the topography. You can make your maps really pretty, very eye-catching, but that's not the only thing that changed in this slide. Now that bottom left-hand table doesn't give that snapshot. It gives something pretty useful that I hadn't seen really in other technologies, which is a market share for each of the major health centers in the area. So our residents work at Erie, which, as you can see on that slide, is a surprisingly small percentage. So we haven't really done a lot with this yet in this demonstration. We've really just typed in the address that we're looking for, and already you can start to conceptualize barriers that are faced by patients. We know that Erie is an FQHC, federally qualified health center. We can see anybody there. We're very close to this address, and still we have a pretty small percentage of patients who are choosing to utilize us for their care. So you can get a lot of information pretty quickly. And speaking of a lot of information, then you can really start to personalize the data that you're looking at, and you can get your own dashboard cooking. So there's a lot of tabs there. For this demonstration, I was looking at low income versus uninsured patients without a medical home. Again, our residents work in a federally qualified health center. This is certainly a group of patients that we could serve and a group that we would be looking to engage as we expand our reach into the community. Going forward, there's even more options. So here we sort of filtered in overall low income and uninsured population. And then you have even more options. So here we added to our dashboard the uninsured population that's below 138% of the federal poverty line. Illinois is a Medicaid expansion state, so it's a group that would be eligible for coverage. And you start to get a dashboard going in a lot of different ways about groups that you're looking to identify. So you see that there's a ton of options for population health. It's a really powerful tool. It's great that there are so many options. I think that can also be a con when you're first starting to use this. It can be a bit cumbersome, maybe overwhelming to see all of those different options as you're beginning to wrap your head around this particular technology. That's fine. I think it's a great tool for population health. It's a potentially very powerful tool. The reason that we ended up going with a different option for the sake of our study was it's difficult to use this at the point of care for a lot of different reasons. And we're also looking for something that, rather than population data and percentages, was more resource-oriented. Another great technology that's relatively new to me is NowPow. It's a powerful technology that gives you a lot of resources, updated very frequently. It has some really unique features. This one's called the nudge, so you can actually send your patients directly via text or email information or reminders about a referral that you've made or about a community resource that you think would be good for them. Providers can get a dashboard about the number of resources, the number of patients that they've provided resources to, and how often they're going. One of the best features, in my opinion, about this particular technology is you can close the loop. So you can link with referral sites and get feedback on the services that were actually provided to the patient. You can add resources as well. So if you see that there's something in the community that you're utilizing, a resource or referral center that's not listed in that technology, you can add it in yourself and keep referring patients there, utilizing some of the other strong points like the nudges and getting the loop closed. It's a great tool. It is not free for everyone to use. It is not readily available. You do have to have a partnership with the company. At Northwestern, all Feinberg students are going to have access starting in this academic year. So at our institution, it's something that we're really starting to utilize. And now we'll talk about this Community Health Resource Navigator that we mentioned very briefly early on. We ended up choosing this one for a few reasons. It's address level data, so again, that's the granularity that we were looking for. Really easy to use and implement at the point of care. Focus on resources over population data. And to be honest with you, I'm a family doctor, and when in doubt, I do what the AAFP tells me to do. And so when I'm precepting residents, I'm often directing them to the AAFP website to look for guidelines or updates. So when we're asking residents to do something new, I think trying to make it as simple and comfortable as possible was important. So this is one less thing that they had to become familiar with because they're already using the AAFP site for a lot of different things. So I think for a lot of different reasons it worked for our program. This one is free and available to use. You will notice the person doing these screen grabs was not signed in, so you do not have to be a member of the AAFP to use this. And when you start, you'll see 3 tabs on the side there. You'll see healthy eating and active living, and then mental health and substance abuse categories that you can choose from. So again, you can start to see right away that this is not going to necessarily be comprehensive. If you are looking for adult education information or end-of-life care services, this tool might not be able to provide you with those resources. It likely won't be able to provide you with those resources. But with those 3 categories, that sort of simple approach of just having those 3 tabs there, you can take a big bite out of a lot of social determinants of health and probably provide a lot of good resources to your patient. Again, this is address level data, so you start by putting in an address. This is the address of one of our clinics that we work in our residency program. And for this demonstration, we chose the healthy eating and active living category. And then you get this map. And when you first start, this map is not particularly useful, but now you'll notice a new menu there on the right where you can start to personalize this to the needs of your patient. So imagine that you have a patient who's struggling with obesity or hypertension, and you want to give them resources on fresh, healthy food. You can start adding in different categories there on that menu. So for here, we added in some markets. Say these are places that are around you where you can go get some better food options. And the patient says, "Doc, that's great, fantastic. I'm happy to do that, but I don't have a car, and so I can't get to those." So you shrink your sort of radius there down to 1 mile and say, here's some places where you can walk. And with your newfound love of exercise, you can keep walking. Here's some parks that are in your area, some places where you can go and be physically active. And when the brutal Chicago winter comes, you don't have to stop being active because here's some gyms in your area that you could, in theory, join and keep moving and keep working towards your goals. If you scroll over each one of those individual resources, you'll get a bit more information. And then you generate your report, and this will print. So this is something that you can hand to your patients at the end of the visit after you've identified, gone through it with them, probably done this in the room with them to talk about the different services they may need. You can hand this to them as they leave. We love handing papers to patients as they leave the clinic. It makes us feel warm and fuzzy as doctors. But these are really good resources potentially that patients can utilize, and it's easy to provide for them. This also prompted a discussion on who is actually doing this. So is this something that the doctor or the resident has to do? Is this something that another member of the team can do, a nurse or an MA? If you have social workers or AmeriCorps volunteers in your clinic, does this have to be done by a doctor? Does it also have to be done at the point of care? So if you're working, for example, in a patient-centered medical home that maybe has some time set aside specifically for panel management activities, or if you're doing pre-visit preparation with your team and you're looking at the patients you're going to be seeing the coming day or the coming week, can you do this sort of proactively and be able to provide it to patients and talk to them about it during your visit as opposed to just giving it to them at the end? So we'll talk a little bit now about a pilot program that we did. So as part of this collaborative and as part of this grant that we received from HRSA, we're being encouraged to try new things, to pilot changes, to see what works, to reassess if we need to do that, and to keep things moving forward. And so that's what we did using these technologies to try and impact education and patient care. A little bit first about our residency community. So the Northwestern Family Medicine Residency Program at Lake Forest Hospital is a mouthful. We serve the Lake County community, which is about 30 to 45 minutes north of Chicago. It is an extremely socioeconomically diverse county. In fact, it's one of the most socioeconomically diverse counties in the country. This is a poverty index, so the darker areas have a higher incidence of poverty. We have 3 main sites within the community. One is Lake Forest Hospital. It's brand new. It just opened in March. It's beautiful and state-of-the-art. It's where the The residents in our program do all of their inpatient work. If you head up north into one of those much darker areas, that's where you'll get to the Erie Health Beach Waukegan site. That's the federally qualified health center serving a very underserved population with a large undocumented population as well. If you head towards the center of the screen, that is the Northwestern Grayslake Outpatient Center. It is a large multi-specialty outpatient center. The Family Medicine Residency Clinic is housed there as well. It's a more traditional outpatient setting. As you get further west of that clinic, you get pretty rural. Again, it's a diverse county. Life expectancy discrepancies approaching 2 decades across neighboring communities, something that we see. So it is a great opportunity to train. I'm one of the faculty members there, so again, I'm super biased about that, but I think it's also a really good opportunity to start exploring some of the differences in population health. So we're trying to, like we talked about before, work towards a higher level of thinking and skill, where we're not just identifying or discussing social determinants of health with our patients, but actually moving towards addressing them. And we think that geospatial analysis provides an opportunity to help us do that. Before we conducted this pilot project, we started by surveying our residents again. The survey was just done for the Family Medicine Residency Program at Lake Forest. We surveyed them about their knowledge and skills with the, as it pertains to these particular social determinants of health domains. What we found was pretty interesting. So in general, they scored themselves pretty low. Our N was never going to be impressive. We have 8 residents per year, so a few apparently were on night float or something when we did this survey. But overall, they scored themselves pretty low on both engaging in conversation and providing resources to their patients regarding social determinants of health. This group of 21 residents included first, second, and third year, so maybe it's not as surprising for first-year residents, but it was surprising to me that the second and third-year residents scored themselves low pretty much across the board, because these are people who have been working in a federally qualified health center for 1 to 2 years and still didn't think they were any good at that. I thought it was just an interesting finding. And again, just highlighted the need to do more. So we started this pilot project by identifying a subset of patients. We chose adult patients with hypertension. The residents were provided their own personal panels of adult patients with high blood pressure, patients for whom they were listed as the primary care physician. We then had them during one of our protected sessions during the week go back and sort of retroactively use the tool to enter the addresses of their patients that they knew, to play around with the different menu options for resources, and to try and personalize it to each one of those patients based on the information they had. And really to see, would this have been useful? Had you had this tool available to you at the point of care, would it have helped you change the conversation? Would it have impacted care in any way? We would have liked perhaps to have a bit more of a specific group of patients. We are working in 2 primary care outpatient sites. Each one of the sites uses a different EMR, and pulling identical patient populations across 2 different EMRs is a very difficult thing to do. I've said I'm not a coder. I think you have to be in order to do that. So we kept it pretty simple. And what we found was that about 58% of the time, the residents said, yeah, this would have been useful for me had it been available. Broken down a little bit further, you see about 61% in the federally qualified health center setting, about 55% in the more traditional outpatient setting. We hypothesized that there would have been a gap. I probably thought it would have been a little bit wider of a gap, but overall about 58% said that this would have been useful and that I would have liked to have had this tool available to me when I was seeing this particular patient. So I think that was a pretty strong number. It's not 100%, obviously. It's nowhere near it. We didn't expect it to be. But if someone said for any patient presentation, for any chronic disease, or any acute complaint, that there was a relatively simple tool that you could use that may impact your conversations or the care that you provide over half the time, would you be interested in learning about it? I think I would have to say yes. So overall, we found these preliminary results to be to be pretty promising. We surveyed our residents again. That is the third survey. They love filling them out. And here's some of the examples. The purpose of this third survey was aimed more at addressing, would you like to do more? Would you be able to like to do more to actually address, not just discuss, but to address social determinants of health? So here's some of the results for mental health assistance. Definitely a perceived problem and wishing that they could do more. This is a particular issue in the state of Illinois. I don't know if anyone's joining us from outside the state. I'm guessing it's also a particular issue in your state. But the lack of resources and trying to find resources that our patient can access is a daily struggle for us here. Housing assistance was perceived to be less of an issue. I don't know if that's because it is less of an issue in the communities that we're serving, or if perhaps we're just not fully addressing that. I think the same can be said about adult education. Is it less of an issue, or are we making some assumptions about the patients that we're seeing every day? And then the last one was nutritional information. Would you like to be able to do more to provide your patients with healthy food options? And overall, again, that was perceived to be a pretty big issue. It's another way to sort of visualize or conceptualize the food issue. So yes, it's an issue. Yes, I'm pretty comfortable talking about it. But no, I don't think that I'm able to do enough to help my patients navigate this barrier that they face. So if you remember when we were doing the demonstration about the Community Health Resource Navigator, this churn tool, the resources that we were able to identify were maybe not as comprehensive as some of the other tools. Notable for us, at least in our program, that the perceived issues in the community were all included in the churn tool. So it still seems to be working pretty well for our needs. Some of the qualitative responses from the residents, both positive and negative. Yes, it gives me some insight, helps me to be able to provide resources, which is nice to give to patients. Some of the limitations, I don't know where this information is coming from or how frequently it's updated. Transportation is such a big issue that our patients face. It would be really nice if we could maybe not just give them information about what's around their home, but if you could overlay the bus routes and say, if you take this bus to get to work, you're passing this many markets or this many parks, to try to personalize it a little bit more. And then just getting more information about languages that were spoken, and do you accept SNAP cards, or do you have reduced rates? Interestingly, again, some information that was included in some of the other tools that we discussed earlier. Some of the benefits, it would be good for community planning. That's something that we've heard from a few of our different residents. So when we had talked about this, it was implementing it at the point of care. What a great tool this could potentially be for asset mapping, or for having our first-year residents or your first-year residents sort of play around with the tool to learn about the community that they're probably new to. I don't have a lot of information about the resources there. And having information at the point of care is just a really powerful thing. The AAFP has the Everyone Project, with the idea that we can transform care, achieve optimal health for everyone. The sort of toolkit for doing that includes addressing social determinants of health in a variety of ways, particularly at the point of care, and trying to utilize new resources to help patients overcome and navigate barriers. I think that geospatial mapping resources certainly fit with that, the call to do that. So the next steps for us, we asked our residents if they thought this would be useful at the point of care, and 58% of the time they said yes, so now they're going to have to do it. And we'll start using the tool at the point of care to see if it's starting to impact the conversations that they're having. We'll start working a little bit more on our own map creation, and then trying to organize GIS resources for everyone to use. This is sort of an example of how we're moving towards accomplishing those next steps by developing our own map platform. This is using the ArcGIS technology, where we can create regular map series highlighting local social determinants of health indicators. We can play around with it, personalize it. It just offers our residents and our learners a little bit more of an interactive approach to create maps, as opposed to just using them. It's interesting and new, innovative way for them to explore and visualize the data and to learn about their community. And that's all I have. So if you have questions, I'm happy to try and answer them.
So thank you so much to Dr. Ravenna. Again, you can either type your question in the chat box, or if you'd like access to the microphone, just click on the little person with their raised hand up at the top bar. Just make sure that your phone or your speakers aren't muted. And while we wait, I'll go ahead and share this final slide. We always appreciate any feedback so we can improve our webinars. So if you have time, please complete our brief evaluation form. And then follow us on Twitter and check out our website for any questions and to continue the conversation. And if you have any questions after the webinar, please feel free to contact me. So we'll wait a few minutes if there's any questions. Okay, Monica, I gave you access. You should be able to speak into the phone now. And we don't hear you, so just double check that your phone or your computer is not muted. Oh, are you there?
Can you hear me now?
Oh, then we can hear you.
Okay, terrific. This is great. Thank you very much for the presentation. This is really fantastic. One question, I know you had surveyed students and now working on residents. Kind of curious on your thoughts on using this kind of tools with medical students as well?
With medical students?
Yes.
Yeah, so I think that's a huge thing that's being explored at Northwestern right now. You know, briefly, we had talked about who is the one actually typing in these addresses, who is the ones who are talking to residents about this. There's so much to cram into a visit. Is this the kind of thing that a medical student can do after the visit? And what a powerful way to have a medical student actually have a very meaningful impact on the patient encounter. I think so often medical students are sort of left shadowing. We really try to not have that be the case. But this is potentially a very specific thing that they can kind of own and do and participate and be a really important member of the care team. At Northwestern in general, like I said, now all Feinberg students are going to have access to this NowPow tool. They all have primary care exposure and experiences sort of longitudinally. We're moving towards getting them all exposure longitudinally throughout all 4 years. So they're going to be in primary care clinics using these tools moving forward. We don't have data about how often they're doing it, although with that particular tool we can get it pretty easily, which is one of the nice things. So yes, I think that this has extreme potential for medical student involvement.
Nice. No, thank you. So just kind of picking up on your last comment that you can track like who's using it or how it's being used. Well,
I'm sorry, say that one more time.
You mentioned towards the end that you can actually track, like, is it like, for example, tracked by resident who's using it or how it's being used?
So the NowPow tool will allow each provider to track their own referrals. It gives you a list of number of patients that you provided resources, how many different resource centers or referral centers that you've tried to pair up with patients, and then you can close the loop on that. So in theory, if each medical student has his or her own account, own logon, they'll get their own dashboard, which is updated sort of in real time, all the time. They can nudge their patients. It's really potentially something great for them to use and for them to follow through. I think one of the other things in medical school is you see that patient for that day, you don't get sort of the follow-up. Northwestern is trying, particularly in primary care, to combat that in a lot of different ways by implementing more longitudinal primary care exposure. And I think this is a great tool to get them to practice how we'll all be practicing one day.
Right. Well, that's terrific. Can they share with each other? Like if a student does their search and another student does, or provider or resident, can they share those resources, or how does
This is
that work?
all brand new to us, so it's really just this 2018-2019 academic year that we're just starting. So starting now, all Feinberg students will get it. So we haven't even used this tool yet. We're just getting started.
Yeah, that sounds great. Thank you.
Thank you.
Are there any other questions? Again, if you want to use the speaker, you'll just click on the raised hand icon at the top bar or type it into the chat box.
So can I ask another question?
Yes, please go ahead.
So just out of curiosity, in your those, I don't know, maybe one of the settings or in your settings, do you have a screening questionnaire for patients as they check in for social determinants of health?
We don't in our settings. It's definitely something that we probably should do more of. I think in the FQHC setting, there are a lot better tools. So I can't actually comment on what they're doing at Eric's residency program. Is split in a couple of different sites, so I can't actually comment on what they're doing there because I only work on the Northwestern side. But on Northwestern we don't, and that I think is a huge gap and something that we should definitely be doing a lot better. Particularly when you see how low of a perceived issue things like housing or adult education resources were perceived to be an issue. I'm guessing that there's a little bit of a disconnect there. So yes, to be honest, those surveys that we did were a bit educational in a lot of different ways. And so I think as we move forward, trying to get more information at the front end is something that we'll be looking to do.
Sure. Well, that would be great. So here at the Cleveland Clinic, just like in the last couple of weeks, starting incorporating something that you can bring into Epic. And to be honest, it's also so new. I'm not exactly sure how or where we're capturing this data, but it's a nice input that then would be nice to link with these other resources. So that
That'd be great.
definitely opens up a lot of opportunities.
Well, thank you very much.
I see we've got one person typing. So from Heather, the question is providing information to patients online feasible rather than printing out all the info? And what percentage of patients in need of resources have good web access?
Yeah, it's a great question. It's a fantastic question. So I don't have the actual data to back all of that up. I mean, I think that they have done studies about how often patients follow through with instructions that are provided to them on after-visit summaries. I do have my own personal biases against after-visit summaries, which is probably reflected in my QI metrics about how often I give them to patients. I think it's just about different ways of access. So you're right, absolutely. Internet access is a huge barrier for a lot of people. We're probably making assumptions again. But we do ask people how they prefer to be communicated with. Do they prefer a call? They get email address, or they give email addresses when they check in now in our clinic if they have one. So we know if that information is available. We're also really trying to get a lot more of our patients to utilize our portal system. So they're getting used to getting information through their email system or through the computer a lot more often. And I just think in general, people are communicating with their doctors utilizing computers, whether it's email or portal systems, a lot more. So while I don't have data to back that up, I think it just provides the option. And like I said, that particular technology is very new to us. So we haven't sort of formalized our approach to how we're going to be getting that information from our patients about how they prefer to be contacted, and then data about how often they're following through based on whether we give them information in the visit or we continue to contact them.
Heather's typing another response. And if there are any other questions, please feel free to type those in as well or raise your hand. So Heather asked, does the tool that you use allow you to email patients or only to print?
This one's only to print. Only to print.
Okay, are there any other questions? If not, we will stick around until 12:30. Thank you so much to everyone who joined us today. Again, we'll send out a follow-up email to everyone who joined with a link to the evaluation form and also to where you can find a recording of this webinar. But again, we'll stick around here if there are any other questions, but thank you so much and have a great rest of your day.
Thank you.